Please start, Asha.
Good evening. Good evening, all. A very warm welcome to ISA National PG online classes. I am Dr. Asha, Senior Resident from Department of Anesthesiology, AIMS Mangalgiri. I will be the screen coordinator for today's session. Once again, welcome to all. It is not uncommon for us to encounter rheumatoid arthritis patients in a day-to-day practice. Today's topic of discussion is anesthetic considerations in a patient of rheumatoid arthritis posted for total hip replacement. Before starting the session, let's invoke the blessings from Ma Saraswati. Now, may I request our Honorable Secretary, ISA National, Dr. Bajwa sir, to say a few words to the. Over to you, sir.
Thank you, Asha. Am I audible? Am I audible to you?
Yes, sir.
Yeah, fine. I think I was having some technical problem with the laptop. Anyway, welcome everyone to the ISA National Online PG classes today. And we have a very wonderful team from Surendranagar under the able leadership of Dr. Reena Madam. She is the dean there. And my screen coordinators will be introducing each faculty individually also. So it's a good endeavor on their behalf to present such a clinical challenging case actually. You may get a PG examination case also during your final, but rheumatoid arthritis, I think almost everyone must have encountered many patients in their lifetime. And these are not so simple patients as it look. They never come with a single pathology of rheumatoid arthritis. Invariably, they are on multiple medications, which alters the pharmacodynamics and possible drug interactions, whether we are going for the treatment pattern or anesthesia drugs. The drug interaction we have to keep in mind. Then many of the patients may be having deformed limbs, and the body structure is also like that the positioning become very difficult. Even the difficult airway cases are also there. You get fibrosis of the cricoordinate cartilage in many of these patients, which has been established in few studies. So another is the airway management. Apart from that, these are basically geriatric patients with all the organs functioning to almost a compensatory extent, maybe 2/3 of their body functions, to their body capacity rather. So these are very, very challenging patients, and anesthesia is not that simple, which is can be considered just a rheumatoid arthritis. So it's a multi-organ directed anesthesia regime which you require during this surgeries, whatever when the major surgery is undertaken. So I think we have got a very good team to develop on this important pertinent clinical problem. So I request Dr. Asha to take it forward from here.
Now, I request Dr. Shweta Rathod, Senior Resident from RIMS, Adilabad, to take you forward through the session. Over to you, Dr. Shweta.
Thank you, Dr. Asha. Good evening, everyone. Myself, Shweta, working as Senior Resident in RIMS, Adilabad, Telangana. It's my immense pleasure to introduce our faculty for today's class. We have three faculties today. One is first Dr. Reena Gadvi ma'am, who is Dean and Professor of CU Shah Medical College and Hospital, Surendranagar, Gujarat. She is ex-HOD of the Department of Anaesthesia, and she is having 25 plus years of experience in teaching and practicing, and has 10 international publications, and special interest is academics. Second is Nandan Upadhyay sir, who is head of the department in CU Shah Medical College and Hospital, Surendranagar, Gujarat. And he is having 20 years and plus of experience of teaching and practicing in anesthesia with 8 international publications. And his specialty interest is regional anesthesia. Third is Anirudh Singh Gadvi sir, who is Associate Professor in Department of Anesthesia in CU Shah Medical College and Hospital, and having 8 and more years of experience of teaching and practicing in anesthesia with 4 international publications. And his specialty of interest is regional anesthesia and segmental spinal anesthesia. Welcome, ma'am. Welcome, sir. A small announcement. Kindly, everyone, please mute the audio and keep the videos off throughout the session. And if you have any queries, please type it in the chat box or raise hand. They will be addressed at the end of the session. Now I request today's faculty to take over the session and introduce your residents for today's class.
Dr. Nandan is there?
Yes. Good evening, sir. Very good evening to all ISA members, senior faculties, consultant, and resident. First, thank you to ISA. Sir, thank you to ISA National Online PG Classes, Honorable Secretary Dr. Bajwa sir and his team, all GC members, for giving Anesthesia Department opportunity to represent at the National PG online classes level. With this onwards, I would like to introduce our third-year resident doctor, Dr. Pooja Patel and Dr. Sanket Patel, who will represent today's topic of rheumatoid arthritis in a patient posted for THR at our institute level. As we know all that, the case today's our program is there is a case presentation of THR and case discussion. After that, there is a question answer with us with routine comorbidities and mortality of the patient, and after that followed by the queries from the audience about answering the question, and after that there is the MCQ presentation with all audience and question answer, and after that discussion is open for all with the patient. So I will let Dr. Pooja Patel to go for the case presentation. Dr. Pooja Patel, please go ahead.
Yes, sir.
Dr. Pooja,
Good evening,
case
everyone.
presentation.
Yes, sir. Good evening, everyone. I am Dr. Pooja Patel, and this is my colleague, Dr. Sanket Patel. We are third-year residents. And beginning with the case presentation, we are here to present on anesthetic management of total hip replacement in a patient with rheumatoid arthritis. So our patient is a 56-year-old female patient residing at Surendranagar, a housewife belonging to lower socioeconomic status, came to our hospital with the chief complaint of pain in small joints of hand since 6 years, with bilateral hip pain and early morning stiffness since 6 years. Patient was relatively asymptomatic before 6 years. Then she developed pain in bilateral joints of hand, proximal interphalangeal joint and distal interphalangeal joint, followed by pain in bilateral knee and hip. The pain was insidious in onset, dull aching in nature, aggravated on cross-leg sitting, squatting, and stair climbing, which was relieved by rest and medication. The pain is non-radiating by nature, associated with morning stiffness of hip, along with small joints of hands and feet, and relieved with activity. Patient pain is not associated with trauma, fever, diurnal variation, chest pain, orthopnea, breathlessness. Patient is a known case of rheumatoid arthritis since 14 years and is currently taking medications, hydroxychloroquine 300 milligram, paracetamol 500 milligram as and when required, methotrexate 15 milligram weekly once along with folic acid supplements. The patient does not have any significant past history related to systemic comorbidities like diabetes mellitus, thyroid disorders, seizure disorders, stroke, angina, or tuberculosis. There is no history of giddiness, sweating, headache, lower limb or facial swelling, or any operative history. The patient's mother also has a history of rheumatoid arthritis. Patient has adequate sleep, bowel, bladder, appetite movement, and is on a vegetarian diet. She is a menopausal female since 5 years. Patient is examined under proper light and exposure, is well oriented to time, place, and person. She is an averagely built, poorly nourished, with a weight loss of 15 kg over 5 years. The current weight of the patient is 58 kg with a height of 158 centimeter, which amounts to a BMI of 23 kg per meter square. There were no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Attempt by palpation per minute, regular in rhythm, and normal force, volume, and tension without any radial or radiofemoral delay, measured in right brachial artery in sitting position. The blood pressure is 130 by 86 mmHg in right brachial artery in sitting position. The saturation is 96% on movement with a respiratory rate of 16 per minute of thoraco-abdominal type. On airway examination, the mouth opening was found to be adequate, which is 3-finger breadth, with a Mallampati grade 2 without any missing or loose teeth. The neck movements and TM joint movements were found to be adequate. The hyomental, thyromental, and sternomental distances were within normal limits. On examination of spine, it was normal with a normal shape and curvature and midline placement. On systemic examination, the respiratory system showed a centrally placed trachea with normal bilateral air entry in all lung zones and clear. The bedside PFT revealed a breath holding time of 30 seconds and a single breath count of 50. On cardiovascular examination, the heart sounds were found to be normal without any murmurs, and the apex beat was placed in 5th intercostal space. The CNS examination revealed a conscious-oriented patient with a soft and non-taptor abdomen. So my probable diagnosis is a 56-year-old female patient presenting with bilateral hip pain who has a known case of rheumatoid arthritis on medication posted for total hip replacement, which I would like to investigate further.
Good evening, everyone. Now, Dr. Anirudh Gadhvi will ask question related to this patient. We discussed the pathophysiology, medical management, preoperative evaluation, challenges during regional anesthesia and general anesthesia posted for non-replacement surgery and post-ASHA. So now I'll go proceed with Dr. Anirudh Gadhvi.
Pooja,
Dr. Pooja?
Yes, sir.
am I audible?
Yes, sir.
Yes, sir. What is rheumatoid arthritis? Describe it and its etiology.
Yes, sir. So rheumatoid arthritis is a chronic inflammatory autoimmune disorder that affects the small joints and often other organ systems, sir. In India, it affects the 0.3% of population. Rheumatoid arthritis seen more commonly in women than men, sir. It has an early onset, and 30 to 50 year of age group is a most commonly presenting age group, sir. There are some risk factors for rheumatoid arthritis, sir. It includes the positive family history, sir. Detectable autoimmune antibodies like rheumatoid factor, RA factor, and anti-CCP antibody. Then female gender, sir. Altered gut flora, food allergies, sir. Cigarette smoking, sir, and psychological stress. For pathophysiology, due to inflammation, it causes the activation of the immune cell production like T cell, B cell, which leads to the pro-inflammatory cytokine release like interleukin-1, interleukin-6, and TNF-alpha, which leads to the synovitis and synoviocyte production, which causes the protease production and osteoclast activity, which ultimately leads to the cartilage and bone erosion with a pannus formation, which causes the rheumatoid arthritis, sir.
Okay. And what are the clinical features of rheumatoid arthritis?
Yes, sir, symmetrical joint pain, sir. Commonly involve joints like metacarpophalangeal joint, distal interphalangeal joint, proximal interphalangeal joint, and metatarsophalangeal joint, sir. With the progression of the disease, it also involves the large joints like shoulder, elbow, hip, and spine, sir. There are morning stiffness in this patient, which improves with a day-to-day activity, sir. Fatigue and weight loss also seen, sir.
What are the other extra-articular manifestation of rheumatoid arthritis?
Yes, sir. For extra-articular manifestation in the respiratory system, sir, interstitial lung fibrosis seen, sir. Then pleural effusion and costochondral involvement causes the reduction in the chest wall expansion, sir. In cardiovascular system, sir, atheromatous plaque formation, which leads to the coronary artery disease and peripheral vascular disease. For cardiovascular system, sir, small and medium vessel vasculitis are more common. And sir, mitral regurgitation also common in cardiovascular system, sir. And in late stage, sir, left ventricular failure also. In hematological, sir, iron deficiency, anemia, and bone marrow depression seen, sir. For nervous system, sir, autoimmune dysfunction and peripheral neuropathy with keratoconjunctivitis sicca also seen, sir. Or some other manifestation like hepatosplenomegaly, sir, chronic renal failure due to treatment, skeletal muscle atrophy, and rheumatoid skin nodule also seen, sir. In this image, there are articular manifestation which seen. In first image, there is a ulnar deviation of the hand, and in second image, botonal deformity and swan neck deformity seen. In botonal deformity, proximal interphalangeal joint hyperflexion is occur, and in swan neck deformity, distal interphalangeal joint is involved, sir.
Very good. Now, how will you differentiate osteoarthritis from rheumatoid arthritis?
Sir, osteoarthritis commonly develops at the later stages of life and is associated with wear and tear of joints. Whereas, sir, rheumatoid arthritis is an autoimmune inflammatory condition, and it often develops at early stages as an onset, which is early compared to osteoarthritis. Sir, rheumatoid arthritis is associated with multiple joint involvement, sir, and the joint involvement is classically bilaterally symmetrical, sir. Whereas in osteoarthritis cases, the joint involvement is often distributed mostly to the large joints and often monoarticular, sir. And sir, osteoarthritis is relieved by pain medication. And whereas rheumatoid arthritis requires management with anti-rheumatoid drugs and biologically active agents, sir, like monoclonal antibodies and interleukin inhibitors, sir.
Apart from clinical features, how will you diagnose rheumatoid arthritis?
Yes, sir. Diagnosis of Arthritis is essentially based on the clinical signs, clinical feature, signs, and symptom. Apart from their positive RF factor and anti-CCP antibodies, there is an elevation of the C-reactive protein and erythrocyte sedimentation rate, sir. There are some radiological findings also seen, like decreased bone density and narrowing of the joint space, sir. And here there are, sir, American College of Rheumatology criteria, as per shown in the slide, sir. There are 4 criteria: joint involvement, serological test, acute phase reactant, and duration of the symptom. If the score is more than or equal to 6, then the definite diagnosis of the rheumatoid arthritis is confirmed.
Okay. Then different pharmacological modalities to treat the rheumatoid arthritis.
Yes, sir. Sir, first of all, I would like to start this patient the anti-inflammatory agents like non-steroidal anti-inflammatory drugs and corticosteroids, sir. Then disease-modifying agents for rheumatoid arthritis, sir. It includes conventional agents, sir, like methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide, sir. For biological agents, sir, B-cell inhibitor like rituximab, T-cell inhibitor, abatacept, TNF alpha inhibitor, adalimumab and golimumab, and interleukin-6 inhibitor, tocilizumab. And synthetic agents include the janus kinase inhibitor, tofacitinib, sir.
Yes. In this patient posted for THR, what treatment is taking this patient?
Sir, this patient is on methotrexate, sir, along with hydroxychloroquine.
Okay, okay. Then how will you evaluate this patient for the surgery?
Sir, first of all, sir, I would like to go for a detailed history taking of the patient regarding the onset of the symptoms along the duration and progression of the disease. I would like to know the joint, all the joints that are involved, any history regarding flares of the patient. And sir, I would also ask about ongoing medication. And after that, sir, I will also look for other systemic features of rheumatoid arthritis, which are extra-articular features, sir. Then I will assess the patient for other systemic comorbidities, sir, like diabetes, hypertension. Then, sir, I will go for a detailed airway examination, sir, as the airway cervical spine is the most commonly involved part of spine in patients with rheumatoid arthritis, sir. So I will go for neck movement assessment of the patient. Especially, I will look for atlantoaxial stability, sir. In cases of erosion of the odontoid process due to rheumatoid arthritis, there can be, sir, instability of cervical spine, which can lead to, sir, spinal cord compression and certain neurological complications like, sir, radiculopathies or quadriplegia. Also, we have to take care while giving general anesthesia to the patient, because head hyperextension during intubation in such cases, sir, can lead to spinal cord compression. So, sir, we can screen the patient preoperatively with an radiological intervention, sir, to look for the joint space. Also, sir, I will assess, look for other joint involvements like, sir, temporomandibular joint. It can lead to difficulty in mouth opening and mastication, sir. We can assess the temporomandibular joint movement by, sir, tests like mandibular protrusion test or upper lip bite test, sir. Also, for us, sir, atlantoaxial joint stability, we can perform a Delicans test, which can help to assess the movement of neck. Sir, there can also be in cases of severe rheumatoid arthritis, there can be cricoarytenoid joint involvement, sir. So we will look for signs and symptoms like hoarseness of voice or any foreign body sensations in larynx, which might indicate a cricoarytenoid joint involvement. Sir, so to summarize it, we should assess all the joints for the range of motion preoperatively in order to optimize the patient for positioning during and after the surgery. And involvement of such joints can render intubation with conventional laryngoscopy difficult And so, sir, we should keep a difficult airway cart ready, and preoperatively should be prepared for any emergency cases, sir. Often we can go for fiber optic intubation techniques.
Okay. Is this patient is having any extra-articular manifestations of rheumatoid arthritis?
Sir, this patient shows reduced single breath count, sir, and also has a reduced breath holding time, sir, which indicates that the patient might have respiratory system involvement secondary to rheumatoid arthritis, sir. So preoperatively, we should also look for pulmonary manifestations, and if required, we should optimize the patient with pulmonary chest expansion strategies, deep breathing exercises, 3-ball spirometry, or chest physiotherapy, sir. And so this reduces the chances of post-operative pulmonary complications, sir, especially if in cases where we need to go for general anesthesia.
Yes, very good. Then what about the anti-rheumatoid drugs during operatives? How will you optimize this patient?
Sir, the drug optimization for conventional disease-modifying agents like sir, methotrexate, hydroxychloroquine, leflunomide, these drugs, according to the latest guidelines, sir, can be continued during the perioperative period. And certain biological agents and targeted anti-rheumatoid drugs like interleukins inhibitors, TNF-alpha inhibitors, and certain monoclonal antibodies, they have to be stopped prior to the surgery at the end of the dosing cycle. So if in this case, if we are going for elective surgery, it should always be posted at the end of the dosing cycle, sir. In case of tofacitinib, it should be stopped at least 7 days prior to surgery. Sir, here the patient is on hydroxychloroquine and methotrexate, sir, so they can be continued perioperative.
Yes. Then what are the common side effects of anti-rheumatoid drugs?
Sir, non-steroidal anti-inflammatory drugs, when used, sir, NSAIDs, they increase the chance of perioperative bleeding, sir. Also, there is increased chance of NSAID-induced nephrotoxicity, sir. In patients where there is a history of chronic steroid use, sir, there can be glucose intolerance, weight gain, sir, increased chances of adrenal suppression, especially for patients who are on chronic steroid use, sir. So in those cases, we need to go for a stress dose steroid administration perioperatively, sir. For patients who are on sir, biological agents, have increased chances of infections, increased chances of reactivation of diseases like tuberculosis, hepatotoxicity, and nephrotoxicity. Sir, for drugs like methotrexate, there are increased chances of pulmonary toxicity, folic acid deficiency. Also, for drugs like hydroxychloroquine, sir, there is chances of, sir, prolonged QT intervals. Sir, retinotoxicity can occur with hydroxychloroquine, sir.
Okay. Then how will you proceed for the investigation to this patient? What are the investigations will you require preoperatively?
Yes, sir. Sir, for I will go for all the routine blood investigations, sir, like a complete blood count. I will look for hemoglobin levels to rule out anemia, as there are increased chances of blood loss in this surgery, sir. I will also look at the WBC count to rule out any active infection. I will go for renal function and liver function test and look for elevated enzyme levels, which can occur due to side effects and hepatotoxicity occurring secondary to a chronic disease-modifying agent therapy, sir. I will ensure that the coagulation profile of the patient is normal, as this patient to rule out any contraindications for neuraxial blockage, sir. And also there will be reduced chances of bleeding in a patient with normal coagulation profile. Sir, I will go for blood sugar estimation in HbA1c level as well, as these patients will have chronic steroid use, sir, so they might have glucose intolerance, and that should be assessed, sir, preoperatively. I will also order a chest X-ray, sir, for this patient to rule out any pulmonary involvement, which is an extra-articular feature for rheumatoid arthritis patient, like effusions or signs of any interstitial fibrosis. In severe rheumatoid arthritis patient, there is development of a restrictive pattern of lung disease seen, sir. So I will order a pulmonary function test and an ABG analysis preoperatively if required. ECG, I would like to look for signs of any hypertrophy, sir, or a bundle branch block. A 2D echocardiography, sir, I would like to order to look for any valvular involvement secondary to rheumatoid arthritis. Also, sir, pericarditis is a common feature. Without pericarditis, without the development of tamponade, is a feature of extraarticular manifestation of rheumatoid arthritis. So to rule out, I would go for 2D echocardiography. Also, sir, to rule out any regional wall motion abnormalities or effusions. Sir, if the patient has any neck movement restrictions, then I will go for suspect that there is cervical spine involvement, and I will go for a preoperative X-ray of XA cervical spine AP and lateral view. And specifically, if the patient has any significant neurological deficits, then we can also go for an MRI preoperatively, sir. If the patient complains of hoarseness of voice or foreign body sensation, which might indicate that there is a cricoarytenoid joint involvement, then we can go for a preoperative ideal indirect laryngoscopic examination, sir, to look for the larynx, sir.
One thing that you would like to check in the 2D echo, what is the most common valvular involvement in rheumatoid arthritis?
Sir, the mitral regurgitation is more common, sir. Pericarditis without tamponade followed by valvular abnormality would be mitral regurgitation.
And now all the things you have evaluated this patient, you know everything about this patient preoperatively, you have optimized this patient, and all the investigations you have required. Now, how will you proceed this patient for the surgery?
Yes, sir. On the day of the surgery, sir, first of all, I would like to confirm the NPO status of the patient, and informed consent should be taken, and we will give the proper antibiotic coverage to this patient, sir, and secure the 2 large ball IV cannula in non-dependent arm, because this surgery is performed in lateral position. And in this patient, the IV cannulation is difficult due to flexion deformity of hand, and radial arterial cannulation also be difficult due to flexion deformity. And I confirm the reservation of the blood products. And if the patient having any comorbidity like diabetes, then I would switch the patient on the insulin and omit the morning dose. If the patient is having any hypertension, then continue the antihypertensive on the day of surgery. In pre-medication, I will give the patient to injection ondansetron 4 milligram intravenously, and injection glycopyrrolate 0.2 milligram intravenously, and injection midazolam 1 milligram intravenously for angiolysis, sir, and injection pantoprazole 40 milligram intravenously, sir. And DVT prophylaxis also be given to this patient, sir, because most of this patient is also bedridden for a long time, sir.
Okay, you have pre-medicated this patient. Now,
monitoring of this patient. Which
yes,
monitoring? Intraoperative monitoring.
Yes, sir. Intraoperatively, first of all, non-invasive BP monitoring, sir. Pulse oximetry, I would like to attach, and then ECG monitoring, sir. And in severe cases, invasive BP monitoring also be used, sir. And input-output monitoring, urine output monitoring, sir.
okay, now which mode of anesthesia would you like to prefer for this patient and why?
Yes, sir. I would like to prefer the combined spinal epidural technique, sir, for this patient. Because epidural catheter also helpful for postoperative analgesia. And if the longer surgery lasts for longer duration, also I will supplement through the epidural catheter, sir. And I will put the epidural catheter at the L1, L2 space, sir. And in spinal anesthesia, sir, I will give the injection levobupivacaine heavy 0.5%, 15 milligram dosage, sir, at the L2, L3 space, sir.
Okay. And if what drug would you like to give for the epidural?
Yes, sir. Ropivacaine 0.5%, and for post-operative, sir, Ropivacaine 0.2% for analgesia purpose through the epidural catheter.
You have opted for regional anesthesia.
Yes,
now,
sir.
what are the consideration of regional anesthesia versus general anesthesia?
Sir, we should prefer regional anesthesias as far as possible in order to prevent, sir, neck manipulation, airway manipulation of the patient, sir. Also, in upper limb surgery, if there is any upper limb surgery, we can go for cervical plexus blocks. But spinal epidural analgesia can also be difficult, especially if the patient has the long-term rheumatoid arthritis and fixed flexion deformities, can render administration of combined spinal epidural technique difficult as well, sir. So in such cases, we can go for administration of general anesthesia, sir. Whenever general anesthesia is considered, sir, we should always anticipate that it can be a difficult intubation, and hence the difficult airway cart should be kept ready. Sir, giving sniffing position or extension, neck extension during intubation can lead to, sir, C1, C2 joint subluxation and can lead to neurological injuries, and so meticulous care has to be taken during intubation. So we can use techniques like manual inline stabilization, and especially if the patient has cervical spine instability and we have screened it preoperatively, we should opt for awake fiber optic intubation techniques, sir.
Yes. Then how will you manage this patient intraoperatively?
Sir, intraoperatively, sir, I will ensure that complete asepsis is maintained throughout all the procedures that I perform, as these patients are at an increased risk of infections due to long-term management with immunosuppressive agents. Also, sir, I will ensure that the patient has a urinary catheter placed, as we have given we have placed an epidural catheter here. Also, the patient would be in a lateral position for a total hip replacement surgery. So I will like to lightly sedate the patient to improve the patient comfort, sir. I can use intermittent boluses of midazolam 1 to 2 milligram for an infusion with injection oxygen supplementation, sir. Also, I will look for, sir, I will ensure that there is pressure padding done at all the sites, as it can lead to development of pressure sores, sir. I will ensure that there is adequate volume given to the patient, and to compensate for the ongoing blood losses, and the blood products are also readily available if required. I will try to provide hypotensive anesthesia as far as possible to reduce the chances of blood loss, also to avoid hypothermia. Perioperative glucose monitoring also becomes an important factor, sir, here, as the patient might be on chronic steroid use. Also, sir, I will look for signs of bone cement implantation syndrome, especially in cases of cemented arthroplasty.
Then what is bone cement implantation syndrome?
Sir, bone cement implantation syndrome occurs due to the cement material, sir. It is a PMMA material which is used, which is polymethyl methacrylate. Sir, there is whenever this material whenever is used, it undergoes a reaction which is an exothermic one and produces very high temperature, as well as the intramedullary pressure also rises along with the temperature. The methacrylic acid, which is a byproduct of this agent, it also causes vasodilatation of the vasculature around the bone, and this can lead to pressure gradient, which leads to traveling of the debris along with the fat into the vascular space and can lead to embolization, sir.
What are the signs and symptoms of bone cement implantation syndrome?
Sir, hypoxia, hypotension, sudden development of hypotension, hypoxia, tachycardia, sir. ECG changes can also be seen, sir, like certain arrhythmias or heart blocks. And sir, even the patient can go into sudden cardiac arrest. So to prevent conditions, sir, we can go for adequate fluid loading and avoid hypotension. We can ask the surgeons, sir, create a distal femoral vent, sir, to release the intramedullary pressure. If at all the patient is under general anesthesia and we are using nitrous oxide, then sir, we should discontinue the use during cement implantation, sir. Also, we should go for we should provide the patient with 100% FiO2, sir, oxygen supplementation with 100% oxygen. Sir, there are certain studies showing use of steroid administration if there is any suspected bone cement syndrome, sir. But I have not seen, sir, any studies which have proven the benefits, sir.
Yes. Now, how will you manage this patient post-operatively?
Sir, post-operatively, sir, I will ensure that the patient has round-the-clock analgesia, sir. The adequate analgesia will lead to, sir, early recovery and early mobilization of the patient, sir, and will help in early discharge, sir. As we have already placed an epidural catheter, sir, so epidural analgesia with ropivacaine 0.2% can be given. Sir, we can also use an additive like fentanyl, or you can go for a continuous epidural infusion technique, sir. Other modalities which can be used are non-steroidal anti-inflammatory drugs, or transdermal patches can be used, sir, or local nerve blocks like lumbar plexus block, or sir, newer blocks like PENG blocks can also be used. Post-operatively, along with analgesia, sir, we can go for thromboprophylaxis. We should shift the patient to an high dependency unit for observation, sir, for at least 24 hours post-operatively. The thromboprophylaxis is an important part. If the general anesthesia is administered, sir, we should go for post-operative spirometry and deep breathing exercises, sir. Also, we should be watchful for adequate return of renal function of the patient after regional anesthesia, and resumption of the anti-rheumatoid medications as preoperative period.
What is PENG block?
Sir, PANG block is a pericapsular nerve group block. It can be used for analgesia for hip surgeries or hip fractures, sir. It is a deposition of local anesthetic agent, which is a large volume, which is 20 to 30 ml of local anesthetic, like 0.25% or 0.5% bupivacaine or ropivacaine, into the plane between the psoas tendon anteriorly and the pubic rami posteriorly, sir. Sir, in our institute, we usually go for USD guided pen block, sir. Sir, it blocks the anterior capsule, now supplying the anterior capsule of hip joint and aids in providing analgesia.
Yes. Now, very good. Now, we have to request Dr. Nandan sir to progress this session.
Now, Dr. Ridhima madam, here is the MCQ for all the participants, 7 to 8. After MCQ 30 seconds, we go for the monitoring of right question and discuss how we will proceed. The first question is rheumatoid arthritis patient on long-term corticosteroid is scheduled for surgery. What is the most appropriate perioperative steroid management? Stop steroid preoperatively, give stress dose steroid perioperatively, reduce the dose by half before surgery, or no need for additional steroid. So yes, most of the participant is given right answer. Not most, all participant have given the right answer. B, give stress dose steroid perioperatively. There is a many formula available in different textbook, but the we follow here is the according to the surgery, major, moderate, or minor. We give in minor cases give stress dose response of steroid in perioperative time. In my minor case, we gave just 100 milligram of glucocorticosteroid on the day of surgery. In moderate case, we gave 200 milligram of corticosteroid on the day of surgery, and after 2 days, 100 milligram. And in major surgery case, from day of 1, we gave 200 milligram of glucocorticosteroid consequently 3 days in perioperative period. Next question. Puja, next question. Which is of the following intraoperative anesthetic complication is most likely to be encountered in rheumatoid arthritis patient with severe cervical spine involvement undergoing general anesthesia? Hypotension due to impaired sympathetic tone, respiratory depression, hypothermia due to impaired thermoregulation, and D, cerebral ischemia due to vertebral artery compression. No, just previous question. Yes, most of the participants is give right answer, not all the. D is the right answer. Cerebral ischemia due to vertebral artery compression. During giving general anesthesia to patient of rheumatoid arthritis with severe cases, we during the intubation we avoid the hyperextension at the atlantic joint. It will produce vertebral artery compression. The next question. A patient with rheumatoid arthritis undergoing total hip replacement develop postoperative hypoxemia and tachypnea. Which is the following is most likely contributing to this finding? A, high dose corticosteroid therapy leading to adrenal insufficiency, interstitial lung disease secondary to rheumatoid arthritis, infection due to prolonged figure, or pain-induced cell of breathing pattern in THR. Yes, most of the participants is the right answer. B is the right answer. In rheumatoid arthritis, there is a restricted type of lung disorder with interstitial lung disease chances. So it is chance that it will lead to tachypnea and dyspnea to this patient. Next question. Which is the following is the concern regarding the neuromuscular blockage in the rheumatoid arthritis? Increased resistance to the succinylcholine, decreased duration of action of non-depolarizing agent, possible prolonged effect due to muscle atrophy, no impact on neuromuscular blockers. Yes, all participants get right answer. Due to disuse or limited movement, there is a muscular dystrophy, atrophy of the skeletal muscles. Neuromuscular junction is less. So possible prolonged effect with normal dose of neuromuscular blocking agent. Next question. Which is the following common cardiovascular manifestation of rheumatoid arthritis that should be considered during the anesthetic management? Heart failure, vasculitis, arrhythmia, valvular heart disease. Yes, sir. There is a definitely value. Yes, there is a valvular heart disease involvement, but as already Pooja has mentioned, the mitral regurgitation is most common in 2D echo finding rheumatoid mild to moderate level. But in the rheumatoid patient, vasculitis is most common complication, which lead to peripheral neuropathy. So small and medium sized vasculitis is very common in this patient, which also causes secondary to many complications. Now, any question, Pooja? You have already answered. Which of the following is the most common presentation of bone cement implantation syndrome during total hip replacement surgery? Sudden onset of hypotension, severe back pain, tachycardia, arrhythmia, and acute renal failure. Yes, already we have discussed. Patient is after cementing within 5 to 10 minutes, there is a hypotension, tachycardia, and patient is complaint of breathless dyspnea. So already all participants has given very good answer to all the question. Any question now? Pooja? Pooja? So the madam, our today's presentation of rheumatoid arthritis with total hip replacement covering all the most perioperative consideration, postoperative consideration, and most significant parts of the rheumatoid arthritis patient we have covered. Now, any queries from the audience? We have open discussion, giving answer and solve the queries, doubt, and related to rheumatoid arthritis. So we can go proceed with this open discussion and question answer session now. Ridhima, madam. We have asked with Dr. Reena madam also, Dean and our past HOD of the anesthesia department. So I will request Dr. Madam, Reena Madam, to say a few words related to this. Give the experience, focus for all, highlight this.
Very good evening to one and all present over here. And first of all, I want to thank the organizer to give us an opportunity to present at this platform, which is for the entire India and our anesthesia fraternity, as well as the PG students, for the better and the best the knowledge from all of the fraternity we can provide at the same platform for all the students. Thank you so much. I think the presentation the students have shared will enlighten the students to perform in their examinations in detail, and we had tried to take as much as possible the knowledge right from the pathophysiology to the perioperative management, goal of the anesthesia, and of course the management of the complication during the perioperative period. So now the session is, I think, open for all, and anything from the audience, we are here to share our knowledge or discuss.
I think Shobha ma'am wants to say something. Kindly unmute your mic, ma'am.
Yes.
Yes, ma'am. Good evening. Good presentation. But madam, here in one thing they have forgot, like injection pause, like 1 gram of pause should be given right before starting the surgery, because we are in having the limited space and want to reduce the bleeding. No need, no tourniquet, so we have to reduce the bleeding somehow. So injection pause 1 gram should be given meticulously. and hypotensive anesthesia should be given to reduce the chances of bleeding in the THR. So,
Yes,
of course,
definitely.
injection pause.
You are absolutely right, ma'am, and we should consider that. Yes. Thank you.
That's what I want to. Rest of the thing is okay. Congratulations.
Thank you.
There
Yes,
is a
Meena.
one question. Capsule is not in total hip replacement surgery, Dr. Bharat sir. It's absolutely right, sir. But we try to cover in a non-replacement surgery, post-operatively in HRA and just like a neck femur surgery, where the rheumatoid capsule is there, and we can give paying block as post-operative analgesia in hip surgery, not in a particular indication.
Hina, ma'am.
Yes.
Which investigation?
Yeah.
Yes, Hina, ma'am.
Yeah.
Very good.
During
Yeah. Good evening, madam.
Very
And
good.
well, yeah.
Madam, your sound is not audible. It's breaking.
Hello. Now.
Dr. Hina, turn off your video and then speak.
Breakdown.
Turn off your video and then speak.
So very good presentation by Dr. Sanket Patel and Dr. Pooja Patel under the guidance of the Reena madam, Dr.
Thank you,
Nandan sir
ma'am.
and Dr. Anirudh sir. And yes, and there is one question for the Sanket. Sanket, as of we know that the rheumatoid arthritis patients, they have the joint deformities, okay? So while intubation, how will you prepare these patients for the difficult airway management for the fiber optic one?
Yes, ma'am. For awake fiber optic intubation, topical anesthesia is essentially making the airway less sensitive, ma'am. Lignocaine is commonly used as a 4% for topical anesthesia, ma'am. And we would perform the airway blocks, ma'am, for awake fiber optic intubation. There is a glossopharyngeal nerve block, ma'am, then superior laryngeal nerve block, ma'am, and then recurrent laryngeal nerve block, ma'am, transtracheal nerve block, ma'am.
Okay, and in the preoperative area, you can go for the nebulization also. The nebulization.
Yes, ma'am. Nebulization also.
Lignocaine nebulization.
Yes, ma'am.
Yeah, good.
There is a one question. What is the intraoperative cementing which investigation? For intraoperative cementing monitoring, we can also go for during monitoring non-invasive ETCO2 monitoring. It is in intubated patient, we can also ETCO2 monitor the ETCO2. During cementing, there is a slightly first sign is rising ETCO2 also. If you apply the non-invasive ETCO2 mass monitoring during intraoperative.
And if you have facility, you can go for ABG also.
Yes, yes, definitely for ABGB. Immediately, we have intraoperative ABG machine is available near to us. We can also go. There is a change in all that.
Yes, sir.
Can I ask one question, ma'am?
Yes, please, ma'am.
Yeah. In that, in spite of paying block, those are the invasive blocks, but then a local infiltration technique. Yeah. Local infiltration.
It's little bit non-audible. Its voice is not clear.
Yeah, madam, local infiltration technique, LIA.
Yes.
With ropiocane, ketorolac, and tranexamic acid. Pause, injection pause 1 gram, ketorolac 30 milligram, and ropiocane 15 ml, 0.5%. That is being given as an infiltration. That is much better along with the blocks.
Yes.
Yes.
LIA.
Yes.
LIA technique.
Yes.
Yeah, LIA.
Infiltration around the operative area along with the block. Yeah.
Yes. So that's one thing which gives a lot of relief to the patient, because these patients need to walk, otherwise they will end up with DVT.
DVT, yes.
Pharmacology is a mechanical thromboprophylaxis. In rheumatoid patient, long term, there is a definitely secondary changes due to pain in the hip and all that. There is a degeneration also due to osteoporosis. There is a definitely rheumatoid lumbar and spinal epidural assessment is difficult in this patient. So maneuvers we can apply for this patient in easily apply the regional anesthesia, central neurological block. We can give for sitting position, we can give femoral block, IV analgesic to this patient also. Or if the hip is in a fixed deformity, before operation we can go for local tenotomy to this patient to make mobile hip to give proper position sitting in this type patient, sitting position. If you want to give regional anesthesia in lateral position, there is a definitely cervical spine is a fit. It also reduce the intravertebral space and easily accessible to epidural and subarachnoid space. So this is very difficult. We can go also for. We can also go for a postoperative epidural is notable lumbar plexus block with use of USD machine or PNS machine. We can go with this patient.
So we have a ultrasound machine in our department, so we can definitely go for the battle blocks with the ultrasound machines, and that can help to the patient. So anything else?
I think for the postgraduate, when we're giving multimodal anesthesia, then the dose of the local anesthetic is also very important when you give it. So one has to calculate it while taking care of that. And positioning, as sir said, can also be facilitated by the pen block. It is the latest block, and you should know which nerves it supplies because it's a sensory, it provides sensory analgesia and a motor sparing. That
Yes,
was
ma'am.
required, as ma'am told, because the post-operative moment and mobilization is very important. And while giving the central erection, you have to care about most of patient if is in anticoagulant or something that needs to be catered off with the coagulation profile. So
Yes,
positioning is one of the thing that you need to, because arthritis itself is a difficult, especially we all have witness in the OT, lying down, making the position. So already patient is in pain. So these are the
total
things that
drug, yes, total local anesthetic drug requirement with the spinal epidural and of course the block need to be calculated before the operative, and it should not go beyond the toxicity level, and that can lead to the other cardiac arrhythmia or sort of things intraoperative periods. Yeah, definitely, that's true.
Madhuri ma'am,
Yeah,
Madhuri ma'am raised the hand. No?
yeah. Thank you, Riddhima. Yeah, very good presentation on a very interesting topic of rheumatoid arthritis. So it is very easy to discuss, but all of us have experienced innumerable problems, especially when you give a case, such a case of rheumatoid arthritis, starting from taking the IV line where the veins are not visible, then to positioning, then the airway, the multiple drugs the patient is on, and then you try to give a regional block, and there again you land with problems. And this is just for the PGs here. You said the patient of rheumatoid arthritis will have atlantoaxial joint problems, right? Subluxation.
Yes,
So
ma'am.
what
Yes.
kind of subluxations do you know of?
Ma'am, anterior subluxation is
Yeah.
more common.
Anterior, posterior, lateral,
Lateral.
and vertical, right? So especially for us, if it is an anterior subluxation, if you're going to flex the neck, you're going to land with problems. And if it is a posterior subluxation, you're going to extend the neck, you're going to have problems.
Yes.
And
Yes.
even for post-operative analgesia, you said you will use patient-controlled analgesia. But for patient-controlled analgesia, you need the fingers of the patient. And many times the patient's fingers will also be deformed.
Deformed.
So he cannot use his or her fingers for that. So that again can become problematic.
Yes, ma'am.
Yes.
Everybody here in the hall, tell me one thing. How many of you really practice the patient-controlled analgesia? Very frank, honestly, how many of you have seen it and how many really practice it and how many have really make you the patient aware that this is the way to control the patient?
Exactly, that was I told them previous day. So nowadays, as a patient control anesthesia, of course, is a modality in written in the books, but it is not that much widely accepted. And rather than giving the patient control anesthesia, there are much more of the other complications because of the patient control anesthesia. Rather, we should go for other systematic, and of course, the local anesthetic under some blocks or during with epidural.
We can go for continuous epidural.
The reason I am asking is,
It is far better to give with the continuous epidural, and the patient
that is
compliance
better.
is very well with the regional anesthesia, particularly the patient having a systemic disease like this, to prevent the other systemic side effects of the IV anesthetic, IV analgesic drugs.
That's what I'm saying, ma'am. In the present
You are
scenario,
absolutely
our
right.
Indian population, the variability in the intellectual level, the educational
So
level, the
unless and until
compliance level, the
yes sir, you are
difficulty
right. Unless and
because of
until
the
it is a contraindicated, it is always a better to give a regional analgesic in post-operative period rather than go for the systemic analgesic. It is always
so I find it
save the patient from the other complications.
it's entirely an academic thing, only nothing more than that. Just for answering the PG in the examination, 99% of the population of anesthesiologists in India don't practice PCA. It's only in the good institutions where you have the good intellectual Amitabh Bachchan coming for surgery, you can give that PCA to them. Otherwise, I don't think so. Even if I am a patient, I will like that somebody is there to help me out during my analgesia. I may overdose myself also. That has to be the thing. I think
It
when
is
you
the
are
main complication. The overdose always occurs,
yeah.
and we may end up in some other complication.
Dr. Mohan Pathak want to say something.
There is a chance of intrathecal.
Sir.
Hello. Sir. The effect of spinal anesthesia will wear off after 1 hour, 2 hours. After that, epidural, you say, when the patient is getting operated on the non-dependent side. This is a simple question. How much, how will you adjust the epidural dose when it is a non-dependent
Sir, we
surgical
cannot
site?
hear you clearly, sir. Sir, please, can you pardon?
When the patient is in the lateral position,
yes.
How will you adjust the doses? How will you manage the doses of epidural when the patient is getting operated on the non-dependent side? Patient is in the lateral position. Epidural, how will you expect to adjust
Sir,
with the hyperbaric drugs?
you are absolutely right, sir. But for the lateral position, whatever the spinal anesthesia we have given, considering the minimum time, I mean possible maximum or minimum time of the surgery, we have to go for it. And for the very you rightly said, so epidural anesthesia in lateral position is not complete required to extend that surgical time. But for a THR, what we do in our department, considering the time of the surgery from the induction, I mean the incision to the complete surgery, we consider that, and accordingly we give the spinal anesthesia. And of course, we use epidural most of the, I mean, maximum for the post-operative analgesia in supine position.
Yes, sometimes it can take very long, 4 or 5 years also. You can give supplement with the sevoflurane with the laryngeal mask and simple things.
Then we have to supplement, of course, with the TIVA or some the general anesthetic agent to extend that surgery. If not, it's not possible with the epidural in a lateral position to extend the anesthesia if the surgery prolongs for some whatsoever the reason. So we have to add guarded general anesthesia, I can say, for some extended period. Otherwise, we have to make the patient supine again and everything. That is a mashup, but we have to go for it.
In between surgery, you cannot make it supine and again. Better to put the laryngeal mask and give sevoflurane on the mask. Thank you. Thank you, ma'am.
Madam, 3.5 like 3.5 0.5% and with fentanyl lasts for nearly 3.5 hours. So that is good.
That is what, madam, I am saying. That is what. See, it is considering the spinal anesthesia with the adequate dose and with the adjuvant. It nearly extend up to maximum more than 2.5 or 3 hours. But sometimes it happens, we may end up in some sort of extended time of surgery. Then we have to go some alternative routes or the modality to continue with that anesthesia. It happens to any anesthesia. See, whatever we selected is the right choice for the right surgery, for the right patient, for the right this comorbidity. But of course, we have to go for some other remedy if we need. It's always there.
But only concern is the lateral position. Sometimes the other hand needs so much that they start moving the upper body.
So
So they have
definitely epidural will not work over there in the lateral position. Of course, that is
sedated.
yes.
And they
We have
need
to
to be
add.
sedated. Yeah. Only thing
But-
that is the only concern so far. That is the only concern so far we
Yes.
have come across. Otherwise, this sort of, if at all that make the little upper body a little bit supine, and you can intubate or you can push in
We have to,
element. That's never.
that is what I am saying. We have to do the patient little bit of supine and go for some IGL or intubate the patient, because already the intubation is a very big concern in this patient. If we select a regional anesthesia in some hurry and sort of scenario, we end up with the intubation complication. So we have to keep it in mind. Of course, ma'am, in my career, I have done the intubation in lateral position. I think no PG student have done so far this, but it happens in the life once in a while. So we go for a, I think supraglottic airway can work in such scenarios sometime. If you want to some extent with the inhalation agent, we can do that. Definitely. With the
Easily
proper,
push in IGL. That's not the problem. Yeah.
IGL is possible. Yes, ma'am. IGL is possible.
Yeah. IGL, you can easily push in IGL. No problem.
Yes.
There will be many brave stories. I've done intubation, LM insertion, lateral position. People will be coming with doubt, but for all the PGs, it is recommended. You cannot do. You should not do. That is for the patient safety is the priority in the practice. When you become a responsible people, not under guidance, when you are doing your own practice, then it's a different story. But for a examination point of view, as a student, don't try anything adventurous on the table. That is a single take home message for the PG students. Those are the modalities which you are require when you acquire the skills of as an independent anesthesiologist. So this is one thing. People will be having many good skills also. People may be doing the intubation prone position also. So that is not your domain. You have to just do the whatever that has been taught in the book by Reena Madam, by Dr. Nandan sir. You have to just go through those chapters.
Yes,
Yeah, books are always the best friend. You should not leave the books. These classes also, somebody was asking about the classes. It will be available on the YouTube. ISNHQ at YouTube, and but for the students, the books are always the primary. These are just supplementary material which will be available on the ISNHQ, uh, the YouTube recording. So it's time that to.
One question answer.
मैडम एक मिनट अभी ना इनको थोड़ा फेलिसिटेट तो कर, इतनी मेहनत की है इन्होंने सबने. So first of all, Dr. Reena Madam, being a dean of a college, know the how many responsibilities are sitting on the seat of thorns. You may be moving very comfortably, but I know how many thorns are there in the seat. In spite of that, you are doing the class and encouraging the professor in head and
it's honor, sir.
And the students, ma'am. So thank you very much for being part of this class as a lead faculty.
Thank you, sir. Thank you so much. Thank you. But I really appreciate whatever the level you are taking our ISA for the downstream to the students. It's really commendable, and I must congratulate you and the whole team for the entire the classes program, and wish you all the best for the future success also. And I assure if you need for any sort of help from our department, we are there to support the ISA, of course. Thank you so much.
Surely, ma'am. Thank you much for the nice words. It's always a teamwork. It's ISA national team as together, not myself alone, ma'am. Then Nandan sir, as a very enthusiastic and young HOD, you did a wonderful job, and
thank you, sir.
Like a battlefield commando, though you took the things upon you. Thank you very much for being the lead of the class, sir. And Anirudh also. Anirudh is a very hardworking guy and is a associate professor. We wish him more luck in the future and more best wishes for his promotions to the different levels in the college. So Anirudh, thank you very much for being. I know you must have done a very hard work with the PG students. I know.
Thank you, sir.
More closely associated with the PG students. Thank you, Anirudh. And Dr. Asha K, she is a class of a screen coordinator at AIMS Mangalagiri. Then our Sweta Rathore also, they both are the screen coordinators. See, it is the confidence after passing out the PG, they are exuberating the confidence on the on-screen, and they will be the future faculty, young faculty of our India. And ultimately, the Pooja Patel and Sanket Patel. So these are the final year students. So you today had a pre-final examination. I think the Dean Madam has seen you performing well. So almost your internal assessment is a
Sir,
100%.
they are already passed their MD examinations.
That's great. That's great. So you must
So,
be giving them some
so
gold
that is
medal
the
and a
reason
party.
they performed very well.
Yeah, you must be giving them party then, ma'am. So they performed very well.
Yes, definitely we are waiting for them. Thank you.
And we wish them from ISA National a very best wishes to them for the future endeavors, whatever they undertake. Now somebody was asking a question. Please go ahead.
Thank you, sir. Thank you, sir. It is our pleasure, sir. There is one question left unanswered, sir. If regional anesthesia is difficult to perform blindly, can we use ultrasound guided spinal?
You have given the answer in the question only.
Actually, someone kept in the chat, sir. So
one more modality is a regional anesthesia to perform under USG. You can do it with the newer modalities under IITV also. So simultaneously, you can use the IITV and the USC. That is also written in the books as well. But you can use if you have enough experience and the other team of orthopedics and radiologists with you. So that can be possible. So both USG and of course with the under IITV, it is possible to give regional anesthesia.
I will be feeling more appropriate with still my instincts and the clinical acumen than the USG. I'm not that much friendly, neither the USG is friendly with me. So I'm more relying upon my acumen only.
Sir, we have done our blocks and regional anesthesia without this type of gazettes. So
Yeah,
of course, we always say it is possible, but we have to be with the newer
yeah, it has to be, but
inventions. We should accept the change and we should use it. Of course, there is always
not
an
just change, ma'am. We have to accept our limitations also. And at this stage, it's very difficult to
the new technology always helps, sir. We have not seen sonography, but with the precise sonographically positioned needle of the blocks, which save many of the drug toxicity, intravascular. See, many
complications.
of the things can be said. It's definitely the safer zone of anesthesia. What we have performed in our era. With new gadgets, there is always a safety profile is increased for the patient as well as anesthetists also.
And apart from that, ma'am, it's not just the newer gadgets, it's the attitude and as well as the learning, the caliber.
Man behind the machine works.
Use how to use precisely these gadgets. That's very important.
Definitely. That is true. Yes, sir.
Any other question, Asha?
no, sir. All the questions are answered, sir. Sir,
It was a good class.
yes, sir.
Definitely, I think very, very informative from to call the comorbidities also. Now Dr. Mohan Pathak are asking what incidence of severe heart disease in rheumatoid arthritis. It's very difficult to define because all the patients of rheumatoid arthritis, they do not present for the surgical. The data, whichever has been quoted in the textbooks, I think that is always taken as a representative after powering the studies of different clinical investigations. So it's a very difficult to define. And what type of heart disease is there? Whether you go for the mitral regurgitation or you have so many other calcification. There are so many diseases. So it's a very vague type of thing to determine at this moment what is the real incidence. So what I have seen in my three cases of over the last 2.5 decades of anesthesia practice. I've seen three difficult cases of difficult airway in rheumatoid arthritis where the trachea was not visible because of cricoretinoid fibrosis. That was the most horrible thing. Suppose you are going for a regional, you have to prepare for the difficult airway also, maintain it. You may say, you may say that the MP grade is 2 or MP grade is a 1. But when you really go for intubation in these cases, the alignment of the axes are not there. The trachea is deviated or it's pulled by the fibrosis. Very difficult. So I think fiber optic, this one, intubation fiber optic bronchoscopy?
Rather than opting the algorithm of the difficult airway, it is better to go for the direct fiber optic and prepare for the fiber optic for the intubation is better rather than going on the stepwise difficult airway algorithm. That is, you are right. That is, I even believe that should be. So it is a safe and secure the airway from beginning is better than going on stepping on the stages of the algorithm.
Anticipating the unanticipated.
Anticipating unanticipated.
Always difficult.
Multi-organ joint deformity, like not only hip, but all other major joints are also involved along with the small joints. So handling and taking care during the positioning, like when you position these patients in a lateral position, like the whole area below this one umbilicus is numb, but then you have to be very careful for the pressure points.
Yes, definitely. There is a peripheral neuropathy also.
Peripheral neuropathy, pressure source and pressure necrosis. So a lot of joints are involved in rheumatoid arthritis. Not only small joints, even the bigger joints are involved. So I myself is a patient of RA.
Oh.
And more importantly, when looking at you, so I can get one more thing in my mind. It's not just about the positioning. So the patient is on the table. I think the prolonged surgery, you have given a regional, you have to sedate the patient. Otherwise, it's a very, very horrible experience for a patient with the discomfort because it's every part of the body will be getting discomfort in a lateral position or any other position. It's always better to have a good sedation level. We are not using any conscious sedation nowadays. It's a sedation level. If you have a good monitoring gadgets, you can go for the sedation monitoring also. Patient should be comfortable because these are the patients who get discomfort even within half an hour of their positioning to a different, which they are not used to in their normal life.
Sir, not only that, they are always on some of the other pain medications in spite of knowingly non-knowing. So their pain tolerance is very high. You have to really give them heavy.
So systemic analgesic agents intraoperatively for the other joints, I mean, in the regional anesthesia is much more needed. I mean, dose is needed for more dose is needed for this patient for the positioning part of the things. And
their pain tolerance is very high, madam. So
very
like that, the smaller
so you
doses.
have to keep it in mind the dosage of the systemic drugs intraoperatively.
So heavy doses, sometimes you need to cover them with very heavy doses because their tolerance is quite high. They were already on pain medications earlier. So their threshold is very high.
Hinaven, your voice is not audible.
Dr. Hina, next time you come to the class, have a good Wi-Fi. Otherwise, I will not allow. As a national GC member, you should have a very good Wi-Fi. You have to buy it. You buy a very good Wi-Fi.
Sir, it is.
Or you call that person who is supplying the Wi-Fi to you. Call that person.
Yes, sir.
Really want to hear from you, and your voice is breaking like anything.
Yes, sir.
You want to ask something? You ask now. No.
No, sir. What I'm telling is, I am agree with the madam that there is a part, but there is a drug-to-drug interaction is also there, and the sensitivity of drug is also expected in the rheumatoid arthritis patients. So we should be looking for all these factors as well regarding the analgesia part.
Yeah, true. Absolutely. Agree with you. Anybody else? Dr. Mohan want to ask again?
Sir, these patients are crippled and these diseases are progressing always. So do you have to take a special consent because you may harm give them more deformity after doing some complex position, and also do you have to take a special consent in presence of already having deformities or these
Sir, see,
things?
that's the sense of this class. We have told at the beginning also, during the class also, these patients have multiple comorbidities. Invariably, you cannot see them a single pathology of rheumatoid arthritis. Consent, sir, whenever any disease is present, so you want to classify it according to ASA or ISA, whatever, ISA 2, ISA 3, ASA 2, ASA 3. You have to take a consent accordingly, sir. You consent, always better to take a high risk consent in this patient rather than suffering later on. So there is no harm.
We take consent considering the whole comorbidity with the present the disorder or disease. So it always count in that our ISA grade and consent from pre-operatively. So it is has to be consented, of course.
Okay, sir. Thank you.
Sir, now I'd like to invite everyone to the this international conference in Chandigarh. It is happening on 25th to 27th July. I had circulated the flyer also. ISA National is organizing in conjunction with the Society of Internal Anesthesia. It's an international conference. So all the PG student SR, you must participate. You don't have to spend that much if you go to the international conference in Europe, America, just end up spending 3 to 4 lakhs. Here you just have to register for the conference and you can enjoy the hospitality of Chandigarh. So I am giving an open invitation to everyone to join this. I will be keep giving invitation every Monday class. PGs are there, so that is a good opportunity for them to have a the certificates of international congress, which is always required by the NMC and other things. Also, that is also important.
Definitely, sir. Our Gujarat state will participate with the full enthusiasm in the World Congress, sir.
Gujarat, I am expecting almost more than 100 delegates.
Wi-Fi ચાલુ થઈ ગયું મેડમ નું સરસ
Yes, yes.
કોન્ફરન્સની વાત આવી એટલે
ના ના એવું નથી મેડમ. Reena madam, you please come to the Chandigarh with the entire team, PG resident and
definitely we'll definitely join there with our few of our departmental
Regarding the chairperson and other faculty, we will be sending invitation in the month of April. So you can still register before that. So we can always go that way.
Madam, come down to the Ahmedabad, we'll go together.
Dr. Reena, call her later for the personal program. So now I think it's a national program going on.
Okay.
So I think I thank everyone for this class, and I thank you all my class coordinators, screen coordinators, and the faculty. It was a really very enriching experience today, and hope to meet you soon tomorrow in the next Monday at the same time. I think another class is going to come. That's a very out of the box topic on sleep apnea and all those things. So Dr. Kavita Lalchandani and her team will be presenting that class. So we'll be meeting next Monday at the same time. Till then, good night from ISA National Headquarters. And we always end by saying long